programs and among, oh, okay, and among the individuals we serve. Our progress and advance in health equity will reflect our commitment to continuous quality improvement for all individuals, and we will incorporate ongoing input from those that participate in the CMS program. All right, it goes on to say CMS has added 7 standardized patient assessment data elements. Those are the SPADs that I was telling you guys about. To the patient assessment tools related to demographic and social determinant of health data. So now they're collecting data based on race, ethnicity, language, need for interpreter, health literacy, transportation, and social isolation for the first time, giving CMS and our stakeholders the ability to tailor programs and policies in post-acute care settings based on needs and disparities. Did someone say something? Okay. All right. So we all know that Medicare is kind of transitioning to this value-based insurance design. And Medicare Advantage is a huge part of that. I don't know about how you guys feel, but I feel like that's kind of where Medicare is going in the future. I feel like it'll be, Medicare Advantage. Right now, they have it's equal. It's about 33 in traditional Medicare, 33 million enrolled in traditional Medicare, and I want to say it was like 30 or 31 million that have these Advantage plans. So in 2021, they started what's called the hospice carve-in. So instead of, how normally when they are admitted to hospice, they just, it's the hospice Medicare benefit. But with this plan, they can choose in-network providers or out-of-network providers that are not in network with their Medicare Advantage plan, and they can actually keep their plan and their benefits. Initially in 2021, there were only about 50 companies that, were participating in this because it is a voluntary program. But since then, the enrollment has doubled. So, 2 years and the enrollment has doubled. I can see that, tripling and quadrupling in the next years. And the biggest benefit to the beneficiaries, the patients, is they're giving them incentives to choose in-network providers. So, I mean, it's looking like, we're going to have to play ball and, get in network and start participating with these Medicare Advantage plans. All right. So another part of this is the Health Equity Incubation Program. And this is pretty much their test program to see, how they will go about collecting this health equity data, and also how they will distribute it. And, more than likely, if they're making these plans, they're going to start, trickling it down to the individual hospice organizations, and they're going to expect us to, report this data to them. Okay, using Z codes to report and analyze social determinants of health. All right, so these are just a few examples of the social determinant of health Z codes. Excuse me. I'm not going to go through this whole list, but traditionally we in hospice have used Z codes to kind of paint a picture of the patient's overall health condition. They have Z codes that show incontinence status, bedbound status, frequent falls. So we've used these codes to, paint a picture, but social determinants of health is also part of that picture. All right, so this is kind of a process that I included in here. This is from CMS. This is actually part of the framework. And this is how you can kind of go about collecting this data and, using it to improve quality of care. All right, so step one, any member of the team can collect this data. For me, I found that most of the social determinants of health data are in our chaplain and social worker assessments, and more so in our bereavement assessment. And I don't know what system y'all use, but the chaplain and our social worker has a bereavement assessment on their initial assessments. So that's where you can get a lot of this data from. All right, so from there, then, usually everybody has a person designated in their office that enters the code. So just like you enter codes, for Alzheimer's or heart failure, you enter these codes in the same place, the same way that you enter all your other codes. All right, and then, if you need help finding the codes, ICD-10, CM, official guidelines for coding and reporting is helpful. But me personally, I normally use Google, honestly, if I'm trying to search for a code. And then also in our EMR, if you just kind of type in a keyword, or even if you type in just Z, it'll show you all the Z codes or everything related to whatever word you put in there. All right, so this data analysis can help you improve quality, care coordination, and experience of care for the patients. All right, social determinants of health data can also be added to key reports for executive leadership and board of directors, or whoever is making the decisions, especially when it comes to equity and diversity and disparities in your organization. All right, and I think this is where you start. Is this your part, Sandy?
Yeah.
Okay.
Thanks.
I'm gonna turn it over to Sandy. You're welcome.
All right. How does the racial makeup of your patient population compare to the community that you serve? That's what we're going to show you, how to find that out. Next slide. Using the patient diversity assessment, you're going to get a report that shows the admissions with demographic data for the last 12 months. Most times in your EMR, you have a report that can show you this. A lot of times it might be one that you use for when surveys there, something like that. But if you dig around, most EMRs have one. You're going to gather this information and note it on the QAPI tool. This is an excellent opportunity to collect beneficial data for your agency. And also it might be a good way to start a performance improvement project. You're always looking for a new PIP. So this might be a good idea to do one for. Next slide. So after you've gathered your data for 12 months of admissions and it's filtered down by each race that you've served, you're going to calculate the totals for each race and input this data into the QAPI tool. You're going to use a separate category for each race. Then you're going to take each race by number and divide it by the total number of admissions. And this will give you the percentage by race that you admitted in your 12-month period. For example, if you admitted 10 Hispanic patients over that year and your total number of admissions for the year was 100, your percentage of Hispanic admits would be 10%. Yes, I used a really easy math example. All right, next slide. So this is part of what the QAPI tool looks like. And this is an example of a calculation for percentages by race. You can see at the top, we have categories for Black, White, Native, Hispanic, Asian, and you can really customize this to make it fit your needs and your agencies. You can see that There's different parishes listed here. And again, you can modify this tool to make it work for your agency. And you can drill down to smaller portions, or you can make it with a broad stroke, whatever works for you. It's really customizable. Next slide. So this is where you can
Hold
review.
on, hold
Okay.
on, it's not
Oh,
clicking.
It
for some
didn't
reason.
move.
Let's see. It's kind of frozen. Let's see here.
Sometimes if you unshare your screen and then share it, you can. And sometimes sometimes Zoom just screws up.
Okay, let me close out. Let's see. I'm gonna close out the PowerPoint and reopen.
There we go.
Okay, let's see. Here we go.
There we go. Thanks, Tamara.
You're welcome.
All right, so this is how the tool looks on one of the tabs, and you enter in your information here and follow the steps, and it's very customizable. Again, you can review it here, and you can modify it for your agency, and you could even modify it for different aspects. You could do one for race, you could do one for gender. You could pick out, which social determinants you're looking to better meet and modify it to meet those needs. All right, and if you look on this this tool, there's a link to the census website that we're going to use, that you'll use to get some of your data from. Next slide. So when you're doing your patient diversity assessment, after you gather your data on your patient population, you're going to go to the website listed above, and it's also on the QAPI tool, to find the population percentages in your area. The criteria can be changed to parish, state, zip code, or city, and you can modify it to best fit the needs of your agency. After you find the percentages for your areas, you want to compare this to your agency's percentages for the 12-month periods of admissions. And when you're comparing the numbers, what you would like to see is that the admission percentages by race, or for whatever you're comparing, is similar to the population in the areas that you serve. So if you see that your numbers are really skewed in one way, then that's something that you want to think about and find some ways that you can address it. All right, Tamira.
Okay, so how to use the staffing equity diversity portion of the tool. So y'all are going to pretty much use the same data that you used for the patient portion. As far as the census data, you're going to use that to compare it to your agency.
Call it a day.
All right, so this is the staff diversity and equity tool. So as you can see here, this is broken down by, just general staff that we normally have in a hospice: administrative staff, nurses, aides, social worker, chaplain, etc. And all you do is, put your totals there. How many administrative staff are Black? How many are white, Native American, Hispanic, Asian, so on and so forth. And then you do that for each different discipline. And then down here at the bottom, it'll give you a percentage. So then you ask yourself, okay, is our overall staff demographics representative of the patients you serve? Yes or no? And then is your overall staff demographics representative of the community you serve? Yes or no? So if the answer is yes, it is representative, great, you're good, you don't need this plan, y'all are doing a great job. If it doesn't, if it's not representative of the patients you serve or the community that you serve, there's an opportunity for improvement there. All right, so what are some of the barriers to staffing diversity? All right, so one of the biggest one is the personal feelings of the employees regarding race. I can remember when I started out in hospice, there were very few African Americans in the hospice industry in this area. But the hospice that I started out with, I never experienced any kind of, negative feelings from any employees or anything like that. Everybody pretty much welcomed me, but I did notice that, like I said, looking around, that there wasn't very many people who looked like me, especially nurses. There were aides, but as far as nursing, social worker, chaplain, administrative staff, there were very few African Americans. All right, and then the racial makeup of leadership. Okay, so what does the leadership look like? What's the racial makeup of your leadership? Your leadership should reflect the area that you serve, especially if you have a high minority population in your particular area. And then also, where are you advertising for positions? Most of us, we use, Indeed exclusively. Everything goes on Indeed. But you kind of have to think outside the box and think of other ways to reach people. I remember at conference last year, someone commented and they said, well, the only applicants that we get are white. We rarely get any minority applicants. So like here we have a newspaper called the Monroe Free Press. It's a Black-owned newspaper. And they have a section where you can advertise. So that could be something, maybe y'all have something in your area that, you could try to post a job and see what you get. It won't hurt to try. All right. So some solutions. Contact your HBCUs in your area to host clinical students. I am actually a graduate of a HBCU. That's a historically Black college and university. I graduated from Grambling State University School of Nursing. So we actually have Grambling students as well as the ULM students, University of Louisiana, Monroe, that come and they, shadow our nurses and our office staff just to kind of see what we do, because a lot of times, especially younger nurses, they don't even know what hospice is. When I got into hospice, I got into it honestly because I had small kids and, I was working 12-hour shifts. I had no idea what it was. All right. Ensure that the work environment is inclusive. No one should feel like they're excluded. Again, utilize alternate job posting sites. And then finally, social media. Unfortunately, we live in a social media world today. It's, everything is social media. So you want to use that to show that your agency is diverse. We all Google prospective employers. I don't know about y'all, but I know I do. Whenever I'm looking for a job. So you want to make sure that what they find about you shows your diversity.
Okay, some benefits of improving services in underserved communities is providing diversity in the services you provide to enhance racial and cultural equity. Some things are ensuring that all communities have access to high quality care. Another one is to increase the knowledge communities have on the hospice benefit that's available to them. You know, a lot of people don't even know that they have hospice available, or that, you know, it's their right to have that benefit. So reaching out to those communities is a way to let them know about that. And building relationships in underserved areas of the community and being able to broaden the availability of resources for patients in underserved communities can be instrumental in increasing inclusion. Increasing the base of patients your agency serves, which can increase referrals and potentially your census, is another benefit. And really the satisfaction of knowing that your agency is delivering quality care to all ethnicities is a large benefit of improving service in underserved communities. Next slide. So some barriers to providing services in those areas, to increase in the diversity in the services you provide. They might include language barriers between potential patients and staff, different religions and religious beliefs, some possible changes in a traditional plan of care that your staff and agency are very used to using, some non-diverse staff in your agency to meet the potential needs of a diverse population. If you don't have any diversity in your staff, it's going to be difficult if you have a very diverse population that may need somebody who can assist them with needs that if you don't have that knowledge base to draw from to help take care of a diverse population, that could be a barrier. A potential provider bias that may be reluctant to refer to hospice due to unfamiliar, okay, they don't know about it, or different views. So that could be some barriers that you have to providing services. Next. So some solutions to those barriers will depend on the one specific to your agency needs, but here's some ideas. One is to build the relationships you have in the community and bridge the gap where it's needed with underserved populations. Another one is to provide education outside of your familiar networks. Extend your outreach to other areas, maybe a partnership with some faith-based organizations, especially the ones that you're not familiar with. You can reach out to some group leaders who advocate for racial equity, groups like the NAACP or a tribal council. Those are some good ideas. Increase staff education on cultural beliefs and diversity to better serve patients. Translation services may be needed. They are available via phone and video. The last time I checked, it's approximately $1 to $2.50 per minute, but they are available if necessary. And this might include translating some of your informational handouts into other languages to some populations that you want to reach. And if you're trying to reach the Vietnamese population, maybe translate some of your brochures, and maybe you need to translate your election of benefits into other languages. Mutual education on cultural rights and beliefs, and attending in-services and providing them to others is a way to show respect and increase knowledge on diversity and equity. So if there's a group in the community, you need to attend their in-services and offer to provide them as well. These can be difficult conversations to have, but one thing we do in the task force is to have them in a non-judgmental space. And it's a good way to start increasing the diversity and equity of the services that you provide in your company.
All right, so that concludes our presentation. This is a list of all the references that we drew from to create this presentation. The executive order that kind of brought all of this about, the link to that if y'all want to kind of go through that and see what all it has in it. There's also a link for the CMS framework for health equity. I do recommend that if y'all are not familiar with it, you familiarize yourself with it because you want to stay ahead of the curve. Also, there's a link to the actual tool here. And that is, well, there's actually two on there, but that's how you get to the actual tool, the actual copy tool. And then there's also some information on the value-based insurance design, if y'all want to read more on that. Okay, any questions? And y'all, if y'all have any questions on, you know, how, once you start using the tool, if you have any questions on how to actually use the tool, or, you know, if you're confused on anything, feel free to contact myself, or I'm sure Sandy won't mind either, and we can kind of walk you through it.
I'm going to put my email in the chat.
Okay, I will as well, if I can figure out, let's see.
We need to say that the tool is actually posted on the page of our health equity page,
Yeah.
web page. So if you just go to the website, you have to sign in, because this is only available to members. You have to sign in, log into the website. And then once you log into the website, you're going to see there are going to be additional pages that members can see that the public can't see. And one of them is health equity, health disparities. If you click on that copy tool that they were showing you, is posted on there, along with some other resources, along with health equities.
Okay, any other
Thank you,
questions?
Cord actually posted the page. So if you want to just click on the page, you can click on that hyperlink
Okay.
that Cord just posted.
Thank you both for doing this. A great presentation and a great tool. I know other hospices I've talked with have been real interested in this and have appreciated you pulling this together and sharing it.
Yeah.
So thank you.
Yeah.
Thank you, Court.
Thanks, Court.
Or are there any questions for Tamira or for Sandy regarding the tool? Anne, you want to just plug the Health Disparities Task Force meeting? What's the next meeting is scheduled for?
Yes, it will be the third Wednesday of April.
Third,
Next,
and it's at 1 o'clock?
yes, and it's every third Wednesday of the month. And anyone who would like to participate in that, either contact me or Cord. We co-chair that task force, and we would be glad to have your input, your perspectives, and for you to become part of our discussion. I want to thank Tamira and Sandy today for this wonderful presentation. I hope those of you who took the time out to join them today got something meaningful and something that you can take back to your organizations.
And I'm just going to ask everyone who's on today's call, if you would mind putting your email in the chat box, your email in the chat box, and we'll make sure that you get a copy of their slide presentation today. So just type your email address in the chat box and I will copy and paste it. And with that, we want to say thank you for your attention today, and have a great rest of the week.
I have one other question, Jamie.
Yes, ma'am.
For the group, for those who are still on the line. Did
Yes,
you
ma'am.
enjoy this presentation, and would you like to have other presentations of webinars presented by the task force? Just a yes or no in the chat box.
Thank you, Ann. Okay. Have a good day, everyone.
Thanks, everybody.
Take
Thank you.
care.
Thank you, Tamira. Thank you, Sandy.
Thank
Well
you.
done.
welcome.
Bye.
Bye.
Well done.
Thank
Bye-bye.
you.
Thank you.